One patient has fever, cough, and infected lungs. Another is drowning in fluid from the inside out. Both may sound wet, both may be short of breath, but pneumonia and pulmonary edema are not the same problem. And knowing the difference matters fast. Welcome back to the Nurse Scrub Club, where we make complex nursing topics simple, visual, and memorable. I'm your nurse educator, RN Karimi. Today, we're diving into why these two conditions get confused and how to tell them apart. Pneumonia and pulmonary edema can look similar. Both can cause shortness of breath, low oxygen, and those wet lung sounds called crackles. But the why is different. Pneumonia is an infection. Pulmonary edema is fluid leaking into the lungs, often because the heart can't keep up. In pneumonia, the air sacs, called alveoli, fill with pus and mucus. This infection triggers inflammation that makes gas exchange difficult. Look for clues like fever, chills, and a productive cough. The patient might also have sharp chest pain that gets worse when they take a deep breath. The story often includes infection symptoms like fever. Remember, pneumonia equals infected lung tissue. In pulmonary edema, the lungs aren't infected, they're filling with fluid. This usually happens when the heart can't pump effectively. Pressure pushes fluid into the air sacs, making it hard for oxygen to enter the blood. This is a true emergency. Patients often look distressed quickly. They might sit straight up, unable to breathe lying flat, a condition called orthopnea. You might see pink, frothy sputum. This isn't about infection, it's about fluid overload in the lungs. Here's the bedside shortcut. Pneumonia tells an infection story with fever and cough. Pulmonary edema tells a heart story. Pneumonia often has localized lung findings, while pulmonary edema usually has diffuse crackles across both lungs. Let's look at a scenario. Your patient has had a cough for several days, feels weak, and gets short of breath just walking to the bathroom. They have a fever and sharp chest discomfort when breathing. This picture should immediately make you think pneumonia. Your assessment focuses on infection signs, sputum color, and whether the patient is tiring out. Localized crackles are common here. Now, scenario 2. This patient suddenly becomes very short of breath and refuses to lie flat. They say they feel like they are drowning. They have a history of heart failure and you hear crackles everywhere. This is pulmonary edema until proven otherwise. This is the patient you do not watch casually. It can escalate to respiratory failure in minutes. Fluid management is urgent. When trying to tell them apart, start with the basics. Listen to the lungs, check for fever, and look for signs of fluid overload, like leg swelling. Ask about their heart history and notice if the lung findings are localized to one spot or diffuse across both sides. The story matters. Treatment follows the cause. With pneumonia, the focus is supporting oxygenation, treating the infection with antibiotics, and managing secretions. With pulmonary edema, we act fast to relieve distress. We raise the head of the bed, give oxygen immediately, and prepare for diuretics to pull fluid off the lungs. For patients and families, keep it simple. Pneumonia means the lungs are infected. Remind them to finish their antibiotics and watch for worsening fever. For pulmonary edema, it's about fluid. Teach them to report sudden swelling, needing more pillows to sleep, or any sudden trouble breathing. Clinical pearls time. Pneumonia is an infection story, pulmonary edema is a fluid story, fever and cough point to pneumonia. Orthopnea and frothy sputum lean toward edema. Remember, both can drop oxygen fast, so treat the cause, not just the sound. Watch for danger zones. Severe distress, blue lips, or confusion. If the patient is working hard to breathe, do not admire the problem, escalate it. Is it infection or is it fluid? That one question can change everything. Thanks for watching the Nurse Scrub Club. Don't forget to like, share, and subscribe.